Hey everybody, this is Dr. Medicine RX, and in today's video we'll be discussing about Kaposi's sarcoma. So it is an idiopathic multiple pigmented sarcoma of the skin. Coming to etiology, it is induced by a viral cofactor, that is human herpes virus 8, and it is also important in the pathogenesis of all variants of Kaposi's sarcoma. Coming to clinical features, so there are four important variants. First is the classical variety, the other is the endemic variety, the third is the iatrogenic variety, and the fourth is the AIDS associated Kaposi's sarcoma. So coming to the classical variety, it is seen especially in Ashkenazi Jews, and it affects elderly individuals and is more frequent in males. So the most commonly affected areas are the distal areas of the lower extremities, and it begins as a blue-red macule that evolves slowly to form a plaque and later on a nodule with a hyperkeratotic surface. So long-standing lesions, they can ulcerate and become secondarily infected. And it spreads in a centripetal manner, and it involves both the extremities, and it also causes edema of the legs. And the course is chronic, and in chronic cases, there may also be mucosal and visceral involvement. Coming to the endemic variety, it is seen in equatorial Africa, and it can be benign nodular variant where it affects young adults, and the features will be similar to classic variant, whereas the fulminant lymphadenopathic variety, which affects children, and it is fatal within a period of 2 to 3 years, and the lesions are mainly confined to the lymph nodes. Coming to iatrogenic variety or the immunosuppressive drug associated Kaposi's sarcoma, it is especially seen in organ transplant patients and those receiving immunosuppressive drugs. And these lesions, they are chronic and they are more aggressive, but the important thing is that they regress after discontinuation of the immunosuppressive therapy. And in prolonged immunosuppressive therapy, dissemination occurs and eventually death occurs. Coming to AIDS associated Kaposi's sarcoma, it is seen mainly in homosexual men, especially those practicing oroanal and anal intercourse, and it occurs when the CD4 cell count falls less than 500 cells per millimeter cube. Especially mucosal sites are involved, such as the hard palate and conjunctiva, and this is usually the first sign of involvement. So here it begins as usual as a small pink to violaceous macule small pink violaceous macule that becomes a plaque and later on a nodule, and when it occurs on the face and the trunk, it follows the skin cleavage lines. So they quickly disseminate over the entire head, face and trunk, and sometimes not mostly in AIDS associated variety, we also see extracutaneous involvement of all the variants. So it involves the lymph nodes, gastrointestinal tract and lungs. Gastrointestinal tracts are especially involved where there can be GI hemorrhage or obstruction. And for one internal lesion and for every 5 skin lesions, there is going to be one internal lesion. Coming to investigations, first is histopathological examination. In patch stage, we see dilated vascular channels that surround the adnexa and other existing blood vessels, resulting in promontory sign. And the blood vessels, they infiltrate in between the collagen bundles of the dermis. And there is also mononuclear infiltrate, mainly consisting of lymphocytes and plasma cells. And these plasma cells around newly formed irregular blood vessels is a clue to early stage Kaposi's sarcoma. So the two important features of patch stage is presence of plasma cells around the newly formed blood vessels, and these blood vessels they are formed around the pre-existing adnexa and blood vessel, leading to the formation of promontory sign. Next, coming to the plaque stage. In plaque stage, there is going to be no atypia, and there are going to be spindle cells that involve the entire dermis and also upper part of the subcutaneous fat, and as usual there is going to be vascular channels, and these spindle cells, they have no atypia. Coming to nodular stage, in this the spindle cells, they get arranged in fascicles and they show some nuclear atypia, pleomorphism and mitotic figures. So in both plaque and nodule stage, PAS positive, that is periodic acid skip stain positive, and diastase resistant eosinophilic spherules are seen in neoplastic cells. Next mode of investigation can be immunohistochemistry, where we can see stains positive for both vascular CD31 factor 8, CD34 and lymphatic endothelial factors such as podoplanin and vascular endothelial growth factor 3. And another test can be HHV8 antigen detection. So the three main investigation choices are going to be HPE, immunohistochemistry and HHV8 antigen detection. Coming to treatment, so localized lesions, We can treat them by simple surgical excision or laser therapy or cryoablation, and sometimes even intralesional vincristine. And for disseminated disease, we need chemotherapy and radiotherapy. So chemotherapy can be done using vincristine, vinblastine, actinomycin D, adriamycin, bleomycin, doxorubicin and daunorubicin. And interferon alpha and beta chain of HCG have also been tried. And the bevacizumab, which is also a anti-VEGF factor, has shown some effect in a subset of patients. And especially in AIDS-associated Kaposi's sarcoma, starting antiretroviral therapy is very useful, and it brings about remission in some of the cases. Thank you. Subscribe for more.